Okay, our next speaker today, we're delighted to welcome Dr. Joyce Van Sluis from the University Medical Centre Groningen. Joyce will talk to us today on total body PET, technical innovation, opportunities and clinical implications. So Joyce obtained her master's degree from the University of Twente before obtaining her PhD at Eindhoven. She became a technical physician specialist in November 2023 and she specialises in radionuclide therapy and dosimetry for personalised treatment. So looking forward to hearing from you.
Thank you for the introduction. Yes, so I'm a technical physician. It's a combination of a physicist and a clinician. If you have any questions, I can talk to you about it later. So my talk is about total body PET, and again, thank you for inviting me to present here at the British Nuclear Medicine Society. Let's start. Oh, I have no conflicts of interest. So at the University Medical Centre Groningen, we were the first centre worldwide in 2018 to install the Biograph Vision, which is the predecessor of the Biograph Vision Quadra. Essentially, the Quadra contains 4 vision systems which are then connected. There's also a CT component, so it's not exactly 4 times bigger. I also talk about the Quadra as we have it, but of course we have the U-Explorer from United Imaging, and I believe also from GE we have now an expandable system that can also be combined to a long axial field of view system. So from 26 centimeters we went to 106 centimeters axial coverage in the field of view, which with lots of additional detectors, of course. This is then a side view, because we have the 2. And the main advantage of an increase in a long axial field of view is, of course, the sensitivity. For comparison, I also included here the MCT and the vision. So the MCT are a photomultiplier-based analog system with a sensitivity of 9.6 kilocounts per second per megabecquerel. We were already very pleased with an increase in sensitivity when we installed the vision to 16.4 kilocounts per second per megabecquerel, and then came the Quadra, which has 2 bars. So the yellow bar represents an MRD of 85. I will go into details later on what that means, in which we already found approximately 77 times increase in sensitivity. And when we expand the MRD to 322, we see an increase of 12 and a half times the sensitivity. So we measured the sensitivity on the Quadra with 2 sets of sleeves to make it more comparable with the original tests, in where the sensitivity sleeves, as shown on the left-hand side, also extend beyond the field of view of the scanner. So this is then the MRD, which stands for maximum ring difference, the crystal ring difference that are actually employed in the reconstruction. So in the raw data, the raw list mode data, we do use all the crystal rings. And in the reconstruction, you can then determine if you want to use the MRD of 85 with a photon acceptance angle of 18 degrees, or if you want to use the MRD of 322 with a photon acceptance angle of 52 degrees, also called the high sensitivity mode and the ultra high sensitivity mode. In the ultra high sensitivity mode, we have more diagonal lines of response, and as you can see in the bottom of the figures, the sensitivity profile of the high sensitivity mode is flat, whereas the sensitivity profile of the ultra high sensitivity mode has a peak in the middle, which leads to differences in image quality over the entire field of view. Towards the edges, the signal-to-noise ratio may be different. So this is something to look into. It can also influence spatial resolution because of the more diagonal lines of response. You have the depth of interaction effect, but also the non-collinearity phenomenon is not so pronounced in the short distance, but with longer lines of response, this non-collinearity phenomenon becomes a little more pronounced. So this is also something to take into account. And in addition, we have, of course, 106 centimeters. This does not fully cover a whole body, usually. Not in adults, at least. So to get a whole body acquisition from vertex to feet, we need to use the continuous bed motion, which also causes a little bit of interpolation, a little bit of uncertainty to where the photons were coming from. So this also maybe have an effect on the spatial resolution, which are still some topics to look into. Well, time of flight, I hope you will all know what time of flight is, but just to summarize, with an improved time of flight, the exact location of the annihilation event can be retraced better by the system, and a better location of the annihilation event means less uncertainty, and less uncertainty means a better signal-to-noise ratio. So with improved time of flight, we get a smaller delta D, so it means less uncertainty. And for the quadra, the time of flight is consistent over a large range of activity concentrations, so it means we can benefit from the time of flight application in a large range of different studies. I will go over this very quickly. It has already been said. Low-hanging fruit, we have better sensitivity and other improved performance characteristics, so our image quality improves. We were already lucky with the vision, so we were already happy with our image quality. Actually, on the left-hand side, then the vision image. On the right-hand side, the long axial field of view image, 14 minutes versus 10 minutes. So to make a more fair comparison, we asked our clinicians to score the image quality of both cameras, but we already reduced the scan duration with a factor of 7 to make it more comparable. And then they said, okay, we see that the overall image quality is very comparable between the quadra and the vision when already reducing the scan duration with a factor of 7. And this was only visual assessment. Now that we have installed the quadra, it would be very nice if we could still use the data and compare it to retrospective data that was previously obtained in other studies, or maybe compare our images of patients with peripheral hospitals in which the patients were scanned before. So for that purpose, we have the EARL accreditation. It stands for European Association of Nuclear Medicine Research Limited, maybe you all know. It was set up for intersystem and international PET image harmonization for reproducible and repeatable image acquisition. For this purpose, you can use the image quality phantom. You fill it with a known concentration sphere to background ratio. Your ideal recovery coefficient is 1. Here's the results measured in the center of the field of view of the quadra. On the top row, you see the EARL1 recovery coefficients. On the bottom row, the EARL2 recovery coefficients. And as you can see, there was no accreditation still for the peak when the EARL1 was introduced. However, we also can see that the quadra performs not so good in EARL1. It's very borderline. The data points are on the limits of, on the lines of, no, not lines of agreement. That's Blendalben. Wait, on the borders of the accreditation. So it's very borderline EARL1 compliant, and we also do not want to downgrade the image quality of the quadra to such an extent to be able to comply to EARL1. Therefore, we recommend to use EARL2, which was also developed for newer systems. Well, this was performed in the center of the field of view. Of course, we also have a longer axial field of view, and these are then the results over the entire field of view. And you cannot really see the data points, which is a good thing in this case, because then it means that the quadra performs very consistently throughout the field of view. Now that we established our EARL protocols, we can continue with evaluating the semi-quantitative accuracy when reducing the scan duration. So this was an example with, on the top row, no filtering. On the bottom row, 2 rows, we have the EARL2 and the EARL1 protocols for the harmonization and standardization. And this is then a zoomed-in version from left to right, 15 seconds of scan duration until 10 minutes. Without filtering for improved clinical reading, we can see that 15 minutes is a little bit too short. We see a large increase in noise. But for EARL2, 15 seconds does not look so bad. And especially for EARL1, of course, when we smooth more to make it more robust to noise, we can, it's acceptable image quality, I think. Then the lesion semi-quantification. We do not want to quantify any images that are not EARL compliant, so let's skip the dark gray boxes, but in the middle and on the right-hand side, you see the gray and the light gray boxes, and you can see that even the SUV max remains very stable throughout all the different scan durations. And this especially accounts for SUV peak, which is even better for quantification of lesions. The coefficient of variation was extracted from the liver to see what the influence of noise was in the images. And from 15 seconds to, from 1 minute to 10 minutes, we can only see a marginal increase of 5% in the noise levels in the liver, which is very acceptable. We would like to maintain it below 15%. And therefore, we concluded that we can reduce at least the scan duration a factor of 10 without impairing semi-quantitative accuracy. And also this can be translated, of course, to a factor of 10 reduced the dose. I had a very nice example here, but I think it's the previous version of my talk. Okay, unfortunately, no nice example of very low dose 0.3 megabecquerels per kilogram image. So we continue with zirconium immunoPET. In zirconium immunoPET, we were used to scanning 20 times longer at least. So we have to take into account the lower activity administration because of the high radiation exposure. Also, of course, zirconium, for example, has a low positron abundance, a factor 4 times lower than, for example, fluorine-18 FDG. If we also take into account the prolonged uptake time for the monoclonal antibodies to actually reach their target, we have to take into account a factor of 2 or 3 decay. So in the worst case, with large antibodies, we even have to scan 40 times longer. So we were very impressed with the image quality we obtained with zirconium immunoPET in comparison to the conventional systems we were used to. So this was a 50-year-old female with metastatic breast cancer, injection of 37 megabecquerels of zirconium trastuzumab, and were scanned at day 4 post-injection. Both images were taken at that day in a sequential protocol. On the MCT, on the left-hand side, the photomultiplier-based analog system, 45 minutes were used to acquire the image, and then it was reconstructed using the EARL-1 protocol to try and minimize the noise. That did not really work. On the right-hand side, we see the quadra, only 30 minutes of scan duration, reconstructed using our clinical reading protocol without any filtering. And we can really appreciate the clear demarcation of all the lesions, even the small lesions. And this is then a similar comparison, but then with the vision, with equal acquisition times. However, the vision image was reconstructed using the EARL-1 protocol, so with a large amount of filtering. And in the long axial field of view acquisition, we did not need any filtering to clearly see the head and neck lesions in this patient. So what does that mean for reducing of the scan duration? Because we see such an increase in image quality, and of course, maybe we are not very interested in reducing the scan duration, but maybe reducing the dose to make zirconium immunoPET also available, not only as a last resort in oncology. I already saw giant cell arteritis in the previous talk. The 3 minutes is not really what we cannot really appreciate the improved image quality in 3 minutes of scan duration, but with, according to the EARL-2 reconstruction protocol, it becomes comparable to 30 minutes vision acquisition, I think. We also quantified this, of course, and now we see that a 30-minute standard axial field of view acquisition with a pretty high coefficient of variation. We would like to have it below 15%. We have a 15-minute long axial field of view acquisition, which can be translated to half the dose and still have semi-quantitative accuracy, as you can see here. Another application, which is very interesting with a high sensitivity, is breath hold, 15 seconds of breath hold PET. On the top row, we see continuous breathing, which may be a little bit blurry. On the bottom row, we see 15 seconds of breath hold, only 15 seconds. And this is even more pronounced in the coronal slice, where we see a smearing of the lesion on the left-hand side during continuous breathing. And we see a clear demarcation of the lung nodule on the right-hand side with 15 seconds of breath holding. Well, this opens up opportunities, I believe, and at our department we are looking into PET-guided biopsies using 15-second breath hold. And now I will move on to the last topic of my presentation, which is a little bit about modeling. I know we are all used to the static PET in clinical application. We obtain a static image. We can derive semi-quantitative values such as the SUV or TBR or relevant other parameters. However, if we have a patient coming in for a baseline scan and we, lymphoma, it undergoes therapy, the patient comes back for follow-up, and then we still make a static scan, one image at one certain point in time, picture. But maybe under chemotherapy, the patient's kidney clearance is altered, and our follow-up scan shows a higher SUV in the lesions. It could be that because kidney clearance is altered, that there is a longer supply of the tracer in the blood towards the tumor. So how can we, there are other factors also playing a role, but how can we avoid this to happen? Yes, so the SUV uncertainty is changes in blood clearance. We can maybe apply dynamic PET, where we actually make a sort of a video and we follow the tracer distribution over time from injection to our 60 minutes, for example. When we get their dynamic image, we can apply a kinetic model to obtain a parametric image. And in the case of FDG, we obtain then a net influx rate, so the rate of tracer uptake in tissue. This is the model that is applied. This is the Patlak model on the left-hand side, and the Patlak plot becomes linear when the free tissue compartment is in steady-state equilibrium with the plasma. So we take into account the plasma, we also take into account the free tissue, and we take into account the trapped tracer in tissue. I already mentioned this. So we obtain, we can compare now different images that we obtain in static PET and with parametric imaging. So in static PET, we obtain the left image, a summed image essentially, which is just a standard clinical image in which each voxel represents the amount of tracer in tissue in a certain point in time. Whereas the metabolic rate, Ki image, represents the rate in which tracer is trapped in the tissue. The distribution volume is correlated to the blood volume. So we can see the summed image on the left, the specific uptake in the middle, and a non-specific uptake on the right. We can make a clear we can clearly distinguish the two now. But how do we acquire such a dynamic image? Previously, with a short axial field of view system, we could only image a small portion of the body at a certain moment in time. So very poor temporal resolution. We had different bed positions to cover the entire body, and we did not have the heart in the center of the field of view at all times. So our input function that we require for the model is well, also not of very high quality, and also we cannot follow clearly the kinetics throughout the body. This has been solved with long axial field of view PET, because we have the heart, and we have all relevant tissues in the field of view simultaneously to follow the tracer distribution towards all relevant tissues of interest, including the lesions. And this is then an example of such a whole body FDG dynamic acquisition. On the Quadra, of course, it was, however, a 65-minute dynamic PET scan. Well, we have just seen that we can reduce the scan duration to 1 minute, and then we come up with an idea to get better quantification or better follow-up scans with 65 minutes of dynamic PET. So there have been a lot of studies which are available in literature. This is by Naganawa and colleagues, but also by ourselves. This is our own work in which we try to use a population-based input function, but also use the image-derived input function of a small portion of the data to still keep the patient-specific characteristics in the blood and the tissue in order to shorten the scan duration of dynamic PET. This was also done by Sari and colleagues, Wu and colleagues, and finally another study by ourselves. So the principle is then that that you capture a later time point, so maybe from 40 minutes to 60 minutes post-injection, or from 50 minutes to 60 minutes post-injection of dynamic PET. With that input function that you capture from that data, you can scale your population-based input function and still get the curve that you need for the model. This is then implemented now also in the Quadra, so I'll come to that later. These are the results. So with 30 minutes, which is still a big increase with respect to 1 minute, but we can get adequate images with accurate quantification. 20 minutes is also still acceptable. However, for 10 minutes, the noise becomes very pronounced, and the quantification is very biased. That was because in the beginning we only had the indirect method to apply our parametric reconstruction. And in indirect parametric reconstruction, we've acquired the dynamic frames, then the dynamic images are first reconstructed, so a dynamic image per frame, and then the model was applied. And this is now possible to do it in one step. And the advantage to do it in one step is that you have a complete overview of the noise distribution in all the data, so we can more precisely model the noise distribution, which leads to improved image quality and improved quantification. Now this is then, these are a lot of examples of different methods of acquisition and different reconstruction, parametric reconstructions, also with different MRD. From the left-hand side, the longer scan duration, towards the right-hand side, the lower scan duration. On the left-hand side, image-based, not really on the Quadra, but well, I believe Siemens, they paid attention to the developments in the field, and now they have a feature that is called multiparametric PET AI, and this allows us to use real-time, live parametric reconstruction in the clinic. And this, the most left two images are shown with only 10 minutes of scan duration. So now we can obtain parametric AI images with only 10 minutes of scan duration, and we have adequate KI lesion quantification still. So this is a big improvement with respect to 65 minutes already. KI remains very similar throughout all the different reconstruction settings and acquisition methods. And here you can also see a comparison between the 30 minutes and the 10 minutes. So the take-home messages, of course, we had the low-hanging fruit. We can, with an increased system sensitivity, we have improved image quality. We can lower the injected dose with a factor of 10. We have low-count PET studies, such as zirconium immunoPET, with higher image quality and lower scan duration, faster scanning, even 15-second breath hold. I would add here the missing example of my pregnant patient with only 0.3 megabecquerels per kilogram. It was a 60 kilogram patient, and we injected 18 megabecquerels in total, and we got a very adequate image quality, very nice. We could even reduce the scan time from 15 minutes to 5 and still have a very readable image. We are still EARL compliant, so with multicenter research we can still also how do you say that? Well, we can still do multicenter research also with other scanners. Improved image quantification through the full kinetic analysis, as I shown you the last couple of minutes. Other opportunities, crosstalk maybe between the brain and the gut, studying the human connectome. This was also mentioned by Dr. Samantha Terry, labeling of immune cells for cell tracking, of course, extended uptake for traces. Maybe there's also an opportunity for longitudinal zirconium, Patlak imaging, ultra-low dose attenuation CT or CT-less correction. yeah, we are also looking into that. Using the tin filter, there was a publication by one of our PhD students, Samane Mostafapour, if you are interested, who have shown that with the tin filter we can reduce the CT dose by 97%, and that was not a typo. Dual tracer imaging or multi-tracer imaging to reduce the burden on the patient. Dynamic FDG PET in 10 minutes, I can say that we already did that. And for full quantification, FDG has a simple model, of course. It's very straightforward. It's trapping of the tracer, not in all tissues, of course. But what about other tracers? We still need very invasive arterial sampling usually, but can we develop models, because we have all the relevant organs in the field of view, the spleen, the liver, can we maybe make a new model to avoid the invasive arterial sampling? So this is developments in the field that are still, ongoing. I'm not sure if I still have time, but I wanted to thank you for your attention, and if there are any questions, maybe now and otherwise later.
That's a fantastic talk, very physicsy for my understanding. I understood bits of it, but when I was taught PET, every photon had 511 keV. So how can you do dual energy imaging? I'm sure there is differences between different isotopes, but if you can just give a little bit of understanding on that topic would be great. Thank you.
Sure, I believe in our center, they are looking into tracers with also a prompt gamma. They have a different, how do you say that? With post-processing, so it's not really available on the system. With post-processing, you can separate the tracers if they, for example, have a prompt gamma, but they are also looking into singles. So the singles, if the Quadra allows you to capture the singles, and through that mechanism, we can also separate the two signals later on. I know that there's also another approach in which we inject ultra low dose administration of maybe fluorinating FDG, and then while the patient was already injected a couple of days earlier, for example, with zirconium. And then we can subtract the zirconium signal from the FDG signal, or the different way around. But at least those are the two approaches I'm aware of.
So it's not simultaneous dual isotope. It's one given earlier, and you are imaging at the same time. But
no, yeah, so that can be one approach. And when we inject simultaneously and one scan, then we have to look into the prompt gamma and the singles. But I'm not the expert. But many of you know Professor Harry Trumpas, I think. He went to Groningen, and he's working on that.
Okay, all right. Well, we'll wait to watch his work. Thank you.
I've got a quick question, Joyce. And it actually is piggybacking on something that Danny said about rethinking. So we've had all these relatively short-lived tracers in PET, O15, N13, rubidium, and we've got all the dosimetry data on these, which were, ultimately acquired and determined in a relatively compromised way. Do you think that total body of PET gives us an opportunity to really revisit dosimetry of these short-lived tracers, because we're going to have real, total body, TAM activity data for all of the critical organs?
Good question. I think, well, because we have such a high sensitivity, we also have, because I know that dosimetry can also be compromised if we have too low counts. So because of the high sensitivity, I think we can at least try to revisit it and try to see if we get different results. But short-lived tracers were not really my specialty, so.
Speakers again, thank you. It was a great session. Really enjoyed it.